Dr. Amit, Dr. Mariano is in India. He's very much in Delhi.
Good evening, Dr. Mariano. Nice to
evening.
have you for this webinar. Thank you.
Dr. Amit Gupta, Dr. Mariano is the Joint Secretary for the Diabetes India as a society, sir.
Very pleased to meet you.
Thank you. Thank you, sir, for accepting the invitation. Thank you so much.
Yes, ma'am. You can start now.
You can start? Great.
Yes, ma'am.
Great. Very good evening, all, and greetings from the Diabetes India Oral Health Group. I take this opportunity to welcome all the delegates, the Diabetes India Head Office, Joint Secretary Dr. Amit Gupta, Secretary General Dr. Bansi Sabu, sir, the webinar faculty, speakers, Dr. Mariano, Dr. Peter, the panel discussion faculty, Dr. Anurag, Dr. Balaji, Dr. Anuj Maheshwari, Dr. Sumida, Dr. Bansi again, and the moderator for the panel discussion for Dr. Amit Gupta. Thank you so very much for accepting the invitation to be a part of this webinar. Well, the topic for this webinar is in very much sync to the important issue, that is oral health and diabetes. And we are well versed of the three salient facts, one being that poor gum health and diabetes has a bidirectional association to the level that periodontitis is a comorbid risk factor for diabetes. Number two, there's been a lot of huge research on this continuum, which led to the release of the practice guidelines for clinicians. And number three step, beyond the guidelines, it is so important to understand how far we have reached in implementing it at the clinical practice level, because we are aware that all scientific research, whatever we do, has to reach the real world setups as well. So today, here we are with an interesting lineup of the agenda with two prominent luminaries of periodontology and diabetology with us at this common platform. Dioh is truly honored to have you both as the speakers. Dr. Mariano, every periodontist relates and know him. He has a humongous research contributions, and most important, we are well versed that he was a key person instrumental in releasing the clinical practice guidelines and recommendations in 2018, which was a collaborative effort on behalf of European Federation of Periodontology and International Diabetes Federation. Thank you so much, sir, because this manual has been a key reference for all that we look up to. Dr. Peter Schwarz, every diabetologist recognizes him as he is the president of International Diabetes Federation. Sir will be joining soon because he has got a different engagement at a different zone of the, So officially we'll be introducing both of you shortly. So with this context in place, allow us to have a small audio visual which is about Diabetes India and Diabetes India Oral Health Group before we initiate the proceedings. Jignesh, audio visual kindly play kar dein. Audio visual. a brief condensed what DIOH and DI talks about. With this, I would like to take this opportunity to introduce the webinar anchors, the moderator and the co-moderator. Can we have Dr. Sumita Bansal's slide, please? Jignesh? Dr. Sumita Bansal, she is the co-chairperson of Diabetes India Oral Health Group. She has been into active academics for the past 16 years and has been into clinical practice ever since. She's an examiner for being the undergraduate and postgraduate students at various colleges with a huge experience as a clinician, academician, researcher, and guide to postgraduate students. She maintains a private practice and she has authored chapters in the specialty textbooks and various publications to her credit. She's a senior consultant at the Accord Hospital, Faridabad, and has a keen interest in periodontal medicine. She has been the scientific convener for Periodiabetes Symposium organized in 2019 and also has been the scientific chairman for the first Diabetes India Oral Health Group Symposium 2024. Can we have the co-moderator, Dr. Gunjan Gupta's slide, please? Dr. Gunjan Gupta, a young dynamic DIOH member. She has an academic and clinical background spanning over 12 years, consultant at various clinics in Delhi NCR, and has her own practice. She conducts various workshops on implants, mucogingival surgeries, and lasers, and has numerous publications to her credit. She's a live member of the ISP and Federation of Special Care Dentistry and IDA. She serves as an assistant editor in collaboration with Federation of Special Care Dentistry. She was honored with Global Professional Award in the year 2022. She also has been a keen interest in periodontal medicines, in specific diabetes and periodontitis. She's been a content developer for JP Publishers. Now, may I request Dr. Sumita Bansal to kindly steer the evening forward, please?
Thank you so much, ma'am. Thank you for the nice introduction. And without any further delay, I think we should be moving on to the lectures. The topic today is oral health and diabetes from research to clinical practice. And for the first lecture, first of all, I would like to introduce our chairperson for the first lecture, who is none other than Dr. Sangeeta Dheer. And kindly, can we have the intro slide of Dr. Sangeeta? Professor Dr. Sangeeta Dheer, she did her master's in periodontology from College of Dental Sciences, Davangere, Karnataka, and clinical externship program in implantology, University of Birmingham, UK. Has been credentialed by the International Congress of Oral Implantology as their fellow. Has been credentialed by Diabetes India as their fellow. Awarded Indian Medical Association Award of Excellence in Dentistry 2024, Indian Medical Association Magnanimous Award of Excellence in Healthcare to 2025, ex-core committee member, National Oral Health Program, Ministry of Health and Family Welfare, GOI. She has served Indian Society of Periodontology in various capacities, ex-vice president, executive committee member, national convener, prenatal periodontal healthcare committee, assistant editor, Journal of ISP, ex-editor-in-chief, Journal of International Clinical Dental Research Organization, has been KOL to various oral pharma companies, was the organizing secretary of the first national symposium in India on periodontitis and diabetes. It was a collaborative event of RSSDI and ISP. She has numerous scientific publications, book chapters, and has been a keynote and guest speaker at several dental and medical conferences, meetings on national and international forums. So I welcome you, ma'am, to please take it forward and kindly welcome our first speaker of the day.
Thank you, Dr. Sumita. Jignesh, can we have Dr. Mariano's slide, please? It gives me immense pleasure to welcome the first speaker for the evening, Professor Dr. Mariano Sanz. He has obtained his, He obtained his medical degree from Universitat Complutense de Madrid in the year 1981. He has completed a specialty in stomatology in 1983 and a doctorate in medicine, PhD at the same university in 1985. Afterwards, he moved to UCLA in 1988 to specialize in periodontology and returned to UCM in 1989 to become a professor of periodontology. He currently serves as professor and chairman of periodontology, director of ETEP, that is etiology and therapy of periodontal and peri-implant diseases research group, and chair of postgraduate periodontology. He is also a type 2 professor at the University of Oslo. He is a member of the Academia Europaea and has received 6 honorary doctorate degrees from the universities of Gothenburg, Sweden, Coimbra, Portugal, San Sebastian, Santiago de Chile, the University of Buenos Aires, and Medical University of Warsaw and the University of Athens. He has published over 500 scientific publications, H-Index 83, and is an international lecturer on topics of periodontology, implant dentistry, and dental education. And more so, we are great honored to have him as an advisor of the Diabetes India Oral Health Group. Dr. Mariano, the stage is all yours. We look forward to hearing you the evening over. Over to you, sir.
Thank you very much. I hope I can share my slides.
Yes, please, sir.
I hope you can see my presentation.
Yes, sir.
Okay, so the topic I'm going to speak today is the impact of periodontal therapy on glycemic control. And I will put a little bit of emphasis in some of the clinical trials and studies that our research group has done in Madrid, which I think can give us some light on this specific topic, which is so important to us as periodontists, but also to the medical community at large. So first, when we are talking about periodontal diseases, what we need to concentrate is on periodontitis, because periodontitis is the real disease that has clearly demonstrated an association with diabetes and hyperglycemia. Periodontitis, of course, everybody understands that it's a bacterial-driven chronic inflammatory disease that is characterized by destruction of the dental attachment apparatus. That is the connective tissue and bone that attaches the teeth to the jaw bones and allow us the very important function of mastication. The issue with periodontitis, mainly when we are talking about severe periodontitis, is that it is the major cause of tooth loss in adults. But what is very important is that it has a very negative impact on oral health quality because of what affects to speech, nutrition, confidence, and overall well-being. Beyond that, we have very clear evidence today that periodontitis, mainly severe periodontitis, is independently associated with many systemic chronic inflammatory diseases, and of course, diabetes, one of the most important ones. So altogether, it is clear that periodontitis represents a very significant public health concern because of its specific oral health problems, but also on the systemic implications. And if we look at severe periodontitis as such, and if we look at epidemiological studies who have looked specifically to the global burden of severe periodontitis in the world, it is the 6th most prevalent disease in the world. And basically about over 10% of the adult population is affected. So you can imagine the dimension of this specific disease that we are discussing. Of course, needless to say that diabetes mellitus is even a more important chronic inflammatory disease that affects mankind. I don't need to go into details on how to define diabetes mellitus and the different types of diabetes mellitus, but what it is important to the topic today is also its high prevalence. If I concentrate in the prevalence in Spain and France, 2 neighbor countries in Europe, we see that the overall prevalence is about between 5 and 10% of the population, which is not one of the highest prevalence in other parts of the world, which sometimes it goes up to 15, 20%. But overall, in Europe, diabetes affects basically 61 million Europeans. And this number is expected to raise to up to 67 million by 2030 and 69 million by 2045. Basically, 1 out of 3 adults living with diabetes are still undiagnosed, and this is a critical issue. And another very critical issue is the amount of over health expenditure to treat diabetes and the overall death toll that this disease has on humanity. So these are really striking figures, and clearly there is a need to diagnose this disease as early as possible and to avoid the complications, because the human cost, the death toll of hyperglycemia is basically the complications that this disease has on different organs, which you can see on the screen, which of course at the end of the road, if it is not treated appropriately, it will cause death. Actually, cardiovascular disease is probably one of the most important complications in terms of frequency. But here we are here to discuss on the association between periodontitis and diabetes, and what we can do in terms of periodontal treatment to impact the course of diabetes and hyperglycemia. And let me start with one of the studies that we did. 2019 we published, although the study was done basically between 2010 and 2015. And what we did is we did a large prevalence epidemiological study on the worker population in Spain, all over Spain. And we evaluated more than 17,000 workers of their periodontal status, but also of the different associated systemic conditions of this working population. And as you can see in the figures, diabetes type 2 was significantly associated with periodontitis, specifically in subjects of less than 45 years, with an odds ratio of 4, which provides you a little bit on the importance of this association. More recently, this was published 2 years ago, we gathered with the main prospective diabetes study that is currently going on in Spain, this acronym Diabet.S. And together with our medical colleagues carrying this huge prospective study, we were able to do a cross-sectional evaluation of the periodontal condition in more than 1,700 subjects. And in this population, again, we had a significant association between periodontitis and diabetes, basically with an odds ratio of 4.9. And basically, through these two studies, we can clearly ascertain that severe periodontitis is associated with diabetes mellitus in the Spanish population. But of course, this not only happens in Spain, and many studies have demonstrated these epidemiological associations, and also we have plenty of studies that have looked at the biological plausibility through different experimental designs. And all these studies have been put together through different consensus workshops and through different meetings that the European Federation, which I have represented, has had with our sort of brother association in North America, the American Academy of Periodontology, and also with very relevant specialist associations in diabetes and medicine, such as the International Diabetes Federation and the World Family Doctors Caring for People in Europe. All these workshops have been proceedings that have been published, and these are some of these publications. But what is important is that through this evidence, very recently, the European Federation of Periodontology published a clinical practice guideline for the treatment of periodontitis. And the whole guidance has been evidence-based using the GRADE methodology. And what is important is that to this very well-proven association, we have included the control of hyperglycemia in patients with periodontitis when they are going through their treatment. And this is the clearly recommended intervention that must be done whenever we treat a periodontitis patient. Of course, as we have said before, many patients with diabetes are undiagnosed, but we need to do a big effort in the clinical setting, in our clinical setting in dentistry, to identify these patients at risk and forward them to the appropriate physicians to have the adequate diagnosis. And now I'm going to be moving to what is really the topic of my presentation, which is what is the impact of periodontal treatment in glycemic control. And since many years, we have been discussing about this possibility, and we have been gathering efforts to undertake the proper clinical trials where this question can be fully answered. Has it a clear impact, the treatment of periodontitis in glycemic control? The first time we tackled this question was in this workshop that the EFP had together with the American Academy of Periodontology. And in this workshop, we reviewed the literature, and we had at our disposal this systematic review that was published in 2013. The workshop was held in 2014. And as you can see in this systematic review, the overall forest plot demonstrate a reduction of about 0.2, 0.3% in the HbA1c levels at 3 months, which may be low, but it is quite significant. And as you can see, we had some studies where this reduction was significant. Others was not significant, but the overall weighted mean was statistically significant. We have more recent systematic reviews that have updated this data. This is one that was published recently in 2020 by a group from the University of Chile. And basically, the results are very similar. The first of the forest plots is the impact on the percentage of HbA1c levels. And you see that the overall weighted mean is a little higher, is about 0.5%. And the lower forest plot is the impact of periodontal therapy on CRP levels. And as you can see also, the impact on CRP levels is very clear and is about 2. So are there any new materials that we can identify apart from the results from these systematic reviews? Well, I would say yes. This is a very important study that was published about 2 years ago, and this was published in Lancet Diabetes, and this is from the group from London, from the group of Francesco D'Aiuto and John Dinfield, and they have evaluated in this 12-month randomized clinical trial in 264 patients, comparing either comprehensive periodontal therapy versus basically supragingival prophylaxis, which is what we regularly call a dental cleaning. And in this randomized clinical trial, the results are even more clear, probably because of the intensity of the periodontal treatment and the very careful follow-up of these patients. But you see, after adjusting for sex, smoking habits, and diabetes duration, the impact was a 0.6% reduction in the periodontal therapy group. And you see here the graph where you see how the directions completely diverge. The group of the intensive periodontal treatment in red and the group with just regular dental clinics in blue. And of course, I would like to mention, perhaps with a little more detail, the randomized clinical trial that we have done in our group, where we have specifically evaluated the impact of periodontal therapy in patients with severe periodontitis and metabolic syndrome. And in this particular study, we gathered with one of the top hospitals in Madrid, where they diagnose patients with metabolic syndrome, and we use one of the systemically accepted criteria to define metabolic syndrome, as you can see in the slide, based on their hyperglycemia, hypertension, dyslipidemia, and central obesity. This was a double-blind parallel randomized clinical trial, and the selection criteria for periodontitis was also very strict because we wanted patients with severe periodontitis. So these patients had lots of periodontal pockets and a very relevant attachment loss. So the experimental design was, again, very simple, very similar to what I have described to the study of Francesco Dioh. In one group, the test group, patients underwent an intense periodontal therapy, which included non-surgical periodontal therapy, antiseptic rinses, and systemic antibiotics. In this case, azithromycin for 3 days. In the control group, they had supragingival professional mechanical plant removal together with the same antiseptic mouth rinse. And we measured all kinds of variables, clinical, biomarkers, microbiological markers, and it took us a lot of time to recruit patients. You see, we screened more than 800 patients, and finally we could include basically about 60 patients in this randomized clinical trial. Basically, as you can see, the patients were very well matched at baseline in terms of age and gender and smoking. And also they were very well matched in terms of the periodontal variables. Basically, as you can see by the percentage of deep pockets, these patients were clearly severe periodontitis patients. And also in terms of the systemic variables at baseline, as you see, the blood pressure, the waist circumference, the CRP levels, the HbA1c levels, triglycerides, cholesterol, HDL, fibrinogen, all were quite well matched at the beginning of the study. You can see here the results, how the impact of periodontal therapy in these patients was very significant. And if we compare the two groups, we can see how the blue, which is a test group, had a very significant impact of the outcome variables evaluating periodontal inflammation, as well as the outcome variables evaluating the number of periodontal pockets. And you can see how at 6 months, the difference between the test group and the control group is not only statistically significant, but very relevant clinically in terms of the percentage of pockets 4 to 6 and more than 6 millimeters. What is important is what was the impact on the systemic variables. And as you can see, the treatment had a significant effect, both intragroup and intergroup, that is the difference between test and control, in terms of blood pressure, CRP levels, and HbA1c percentage at 3 months. At 6 months, the significance was still maintained for CRP levels and for blood pressure. Also, there was a clear impact on biomarkers, important pro-inflammatory biomarkers as interleukin-1 beta, TNF-alpha. And as you can see, those impacts were both in blood as well as in gingival clavicular fluid, what not only indicates the local impact, but also the systemic impact of periodontal therapy. And clearly, probably the biggest of the impacts took place in terms of C-reactive protein. You can see a 30% reduction between the group that had the intense periodontal therapy versus the group that had only preventive therapy. So beyond the CRP protein, also there was a clear impact on HbA1c levels at 3 months and on blood pressure. This has also been reported in other studies, the very important impact on blood pressure of periodontal therapy. And of course, we may say, what is the clinical relevance of these 0.5, 0.3 reductions in HbA1c levels that we have described, from the 0.3 of the first systematic review to the 0.5 to the 0.6 of the Francesco Dioh randomized clinical trial? Well, according to this publication, each percentage point of decrease of HbA1c results in a 30% reduction in risk of macrovascular complications. So 0.6% seems to me a very high impact in the management of these patients. So an average reduction of 0.2% is associated with an all-cause mortality reduction of about 10%, which is very relevant. And I like to always present this study. And this study, of course, is a calculation in terms of cost effectiveness. But these authors have used a big database, the NHANES database from United States, to do their calculations. And they have done a cost-effective analysis to estimate lifetime costs and health gains of treating the oral health conditions of type 2 diabetes patients. And as you can see in the results, if we expand periodontal treatment coverage among patients with diabetes type 2, it is expected to avert tooth loss by 34% and microvascular diseases by 20%, and 20% for nephropathy, neuropathy, and retinopathy. So this provides a clear message that if we are able to convince our authorities that providing non-surgical periodontal therapy to patients with type 2 diabetes and periodontitis, it is expected to reduce significantly not only tooth loss, but also the microvascular diseases and the total death toll of these populations. So what are the implications? And the implications clearly, and this is something that we have discussed with the European Union of General Practitioners and Family Physicians, should be to combine efforts both in preventive strategies and also in strategies by dentists to detect subjects and the risks. And this initiative was part of the discussions that took place in this workshop 2017 that I had the privilege to chair, and which the publication provides, I think, clear guidelines to all the different stakeholders that intervene in these patients that have both diabetes and periodontitis. So we provided recommendations of what they should do and what they should know to oral health team, to patients, to medical professionals, to researchers, and to policymakers. And this document has been quite cited, and I think has had a good impact, not only in our oral health profession, but also in other health-related professions. In terms of what we can do for screening and diagnose patients, let me share with you a study that we have done in Spain. This study is called Diabetes Risk Studies. And here we have joined forces with the Spanish Society of Diabetology and the Spanish Society of Periodontology. And through a research network of dental clinics, we have evaluated over 1,000 patients. And the overall goal of this was to see if we could screen and diagnose diabetes mellitus or prediabetes just by doing very simple screening exercises in dental clinics. So basically, it was a cross-sectional study involving first visit patients attending this network of 41 dental clinics in Spain. We wanted to evaluate patients that didn't have a prior diagnosis of diabetes mellitus or diabetes, and of course, patients that had other systemic conditions that could affect this screening. So basically, we started with the FINRISK questionnaire for diabetic risk factors. We did, of course, the periodontal examination, and we did a point-of-care HbA1c evaluation whenever the FINRISK had a score of more than 7. If the HbA1c value was over 5.7%, then we sent a formal letter and addressed the patient to their physician to have the proper diagnosis of either diabetes or prediabetes. And as you can see, the results were very promising. Basically, 8.5% of the patients were diagnosed of glucose metabolism disorder. 69 patients, 6%, were diagnosed of prediabetes, and 28 patients, 2.5%, were diagnosed of diabetes type 2. And has to be clear that all these patients were undiagnosed before going to the dental clinic. So, as a conclusion of my presentation, I have tried to base the question of what is the impact of periodontal therapy on diabetic control on the clear association of severe periodontitis with hyperglycemia and diabetes, and how we need to treat effectively severe periodontitis to demonstrate that there is a clear impact in glycemic control. Also, I have tried to look at what preventive measures we can undertake working together, the medical profession and the oral health professionals. And with this, I send you greetings from my city, Madrid, and hopefully you are able to visit us one day. Thank you very much.
Thank you, Dr. Mariano. This was an insightful lecture, and it's been an honor to hear. All the participants are glued, and we don't see any chat box messages. Perhaps they were totally involved in your lecture. That I think I was involved, so I'm assuming for everybody. So it was a delightful lecture, sir. And let us welcome Dr. Peter Schwartz. Good evening, sir. Finally,
good evening. It's an honor to be here.
He has finally joined. And allow me to introduce Dr. Mariano San, sir. He has just finished his lecture right now. And Dr. Mariano, how much time would we have with you, sir, before you move on to the next engagement, sir?
15 minutes.
15 minutes. So maybe can we have one or two questions, sir? Maybe if you allow.
Please.
Yeah.
Please.
So basically, sir, maybe one point we could have a question as when we talk about invasive and non-invasive, testing. Okay. How do you assess salivary biomarkers as in a method of glycemia, checks without entering the blood? How would you grade it as?
Well, the problem is that there are not real validated methods to test glucose level in saliva, and there are not validated, so to say, diagnostic devices that they do so as it is done normally in blood. So this is an area that a lot of work needs to be done, but basically we evaluate all kind of biomarkers in saliva and in gingival clavicular fluid.
Right.
But unfortunately, glycemia is one of those that is not really validated by science.
Right, sir. Till a time when we have some validation from saliva, probably it will be a gold mark, to utilize it as a non-invasive tool. Right. So can we have your experience back in Spain about, the oral health and medical, integration aspects that is the biggest gap that we are seeing in Indian scenario? Could you share your experience at your country, sir?
Sure. I mean, of course, the relationships must be based on trust, and to have the trust from the medical profession, you need the scientific support that what you say and what you claim is fully supported by science.
Right, sir.
So when we started 25 years ago, we had problems because the studies we had were merely observational studies.
Right.
The associations sometimes can be spurious associations.
Right.
So we were very excited by these associations, but of course the medical profession were telling us, yes, indeed, but you have to show impact and you have to show real outcomes and not so many surrogates as we were doing at the beginning.
Right, sir.
But with time, now I think after all these years of very good research all over the world, there is no doubt, and all the medical authorities and the international diabetic authorities have clearly recognized severe periodontitis as a clear side effect or a clear complication of diabetes. And of course, the other way around, the bidirectional effect of periodontitis on glycemic control, of course. And also, I think is very important that these studies that I have mentioned on collaboration in terms of diagnosis or in terms of helping for diagnosing people, I think the medical profession appreciate very much these efforts because, of course, we dentists, our role is to treat oral conditions, not to diagnose diabetes. But if we can do these screening efforts and send the patients with risk to the medical profession, I think this is an important role that we can do for a fair and trustful collaboration.
Right, sir. Right, sir. May I request the faculty, would you like to have one more with Dr. Mariano before we, say goodbye to him? Dr. Balaji, please.
Yeah, good evening, Dr. Mariano. That's a wonderful lecture. Thank you very much for giving us this opportunity. You also mentioned about the reference between the practitioners. So can you let us know what could be the practical steps to set up the referral pathways between the dentist and the medical practitioners?
Yes, I mean, one of the things we have done, and you have seen the results in the publications, is that we have asked the big players in the big diabetic epidemiological studies, if they would allow us to study the oral component. This is not easy because these studies are very large studies, so you need a lot of manpower to do that. And so far, we were able to do a cross-sectional study in the year 2024. But now we are going to continue and to look, because this is a very large prospective study that is well supported by the government. And the whole idea is basically to evaluate not also the oral component, but the overall medical component, to have a clear picture on the real risk factors that affect diabetes evolution and the impact of complications.
Right, sir. Right, sir.
Thank you.
Yes, Dr. Anurag?
Yeah, thank you, ma'am. Professor Mariano, wonderful lecture, and I am so thankful that you were able to provide evidence on the linkage, because it is often questioned, and only because of these large studies and that we are able to now put the evidence. But at the same time, I would like to ask you as a researcher, because now we are in an age of comorbidities. Patients are coming with medications, and there are so much confounding factors. So how difficult it is in order to actually find that link?
It is very difficult. Mostly the intervention studies are extremely difficult, because the problem is that the patients that are diagnosed with diabetes, they are well medicated. So to have an impact on HbA1c levels is very difficult, because those patients already have 1, 2, 3 hypoglycemic medications. So that's why in our study, we could only select 60 patients out of screening more than 800, because of the very strict inclusion criteria, where we were trying to avoid all these confounders. So it takes a big effort, and indeed, intervention studies are very difficult, but it is the only proof, or not the only proof, is the main proof. And this we need to pursue, because if we don't do these intervention studies, our claim to the authorities to provide periodontal therapy as part of the treatment of diabetes, for those, of course, diabetes patients that also have periodontitis, is critical, because one thing is to be a risk factor, and another thing is that the treatment of our oral condition has a clear impact on diabetes. This is very strong.
Thank you, sir.
Right, sir. Thank you so much, sir. I think we will, if you are welcome to join, we'll be more than happy to have you on the panel discussion, but I'm sure you're having your engagement, sir. So thank you so much on behalf of Diabetes India Oral Health Group, sir. And we look forward to seeing you. Tomorrow we'll be hearing your lecture again, sir. And
Thank you.
see you, sir. Thank you so much, sir.
Thank you very much.
Bye,
It's a
Good
pleasure.
night, sir. Good night,
Good
sir.
night.
Bye-bye, sir. Bye, bye, bye.
Thank you so much, Sangeeta ma'am. Thank you so much, Dr. Sands. And now I think I'll request Dr. Gunjan to please come and introduce our next speaker, our next chairperson.
Thank you, Dr. Sumita ma'am. Jignesh, can we have the CV of Dr. Banshi Saboo? A very good evening to one and all. It gives me immense happiness to welcome our next chairperson, Dr. Banshi Saboo. He's the Chief Diabetologist and Chairman of Dioh Diabetes Care and Hormone Ahmedabad, Global Council member EASD, Chair International Diabetes Federation IDF of Southeast Asia, Secretary Diabetes India and Indian Academy of Diabetes, Vice President Diabetes Asia Study Group, founder of D-Tech Diabetes Care, member advisory group of American Diabetes Association, and past president of RSSDI and AAIRO. He has many fellowships to his credit, and to name a few: American College of Endocrinology, Royal College of Physicians, MNAMS, Diabetology, and he has many editorial positions as well, like managing editor, Editor-in-Chief, Journal of Nutrition, Metabolic and Health Science, Editor-in-Chief, Diabetes and Metabolic Syndrome, Editor-in-Chief of RSSDI Textbook of Diabetes, and he has several awards and achievements to his credits, like World Health and Wellness Congress and Awards have awarded him the most impactful healthcare leaders. He has been awarded by AACE as a Global Clinician of the Year 2024 and initiator of RSSDI Defeat Diabetes campaign for world record of 1.2 million screening on World Diabetes Day. We welcome you, sir, and I request you to kindly introduce our second speaker of the day, Dr. Peter. Thank you so much, sir. Over to you, Dr. Banshi Sabu, sir.
Hello. First of all, thanks, Sangeeta, for inviting me. It's a wonderful that it is one of the most active group. I mean, we are very happy to share with Dr. Peter as International Diabetic Federation that this group which we started in India and, inviting dentists and oral health specialists, which is a area which is completely not very much recognized neither by physician and diabetologists, and at the same time all those who are expert in the field of oral health, all dentists, they are also not very well versed with the diabetes complication. They may tell their patient that you keep your sugar control. So what we thought of under Diabetes India, that nationally we want to create a lot of awareness amongst our dentist colleagues and friends, and at the same time, the physician and diabetologist, they completely forget the patient to tell that you go and see your dentist or go and check your oral health also. That's what required twice in a year. Even international organization like American Diabetic Association, in their guideline, are writing that it should be done twice in a year if possible. And if there is a comprehensive diabetes clinic, like I have since last 10 years in my clinic, a dentist working with me, and we have each and every patient to go and see dentist at least once in a year. And we in India is also one more challenge of taking tobacco and pan masala. That's again a challenge which is not anywhere in the world, probably more common in Southeast Asia. So being as a chair of Southeast Asia, chair of International Diabetic Federation, I thought that we should create a lot of awareness. I'm very happy today that Professor Peter Schwartz agreed and he accepted, even with a very busy schedule which he's having. I can know that he's almost for 10 or 15 webinars and inaugurating so many things, very, very active all across the world. I can see, I mean, I can't just even follow him. And he's really get engaged with all those activities every day, which I see, meeting different people from all over the world, and very active. And we always feel very enthusiastic after seeing him doing a lot of activity. We are completing our 75 years of International Diabetic Federation. Very excited, the month of March, and we planned our IDF reception even at Vienna ESD meeting, one of the largest meeting of diabetes, European Association of Study of Diabetes in Europe, in Vienna, where we are going to have it this Wednesday, 75 year. Also, we are going to celebrate, and for next 1 year, we are going to have a lot of programs. And as a Diabetes India secretary, me and Amit Gupta, we decided that India will be very active to participate in this 75 years of IDF celebration from India. As a chair of IDF Southeast Asia, even we want to do a lot of activity. And this is one activity of diabetes and oral health. Probably we want to increase awareness amongst the physicians. And I'm really thankful to Sangeeta and with his team. I just want, Sangeeta, that, more and more dentists, but more and more physicians can join this meeting that I wish for. And it's really my great pleasure to introduce Professor Peter Schwartz. I mean, he's the International Diabetic Federation president, but if I can have his slide, I can formally introduce him to all my colleagues who are not diabetologists or physicians, because across the world, more than 1 million physicians who are practicing diabetes, they all know Peter. So, I mean, it's only few dentists may not know him, but I'm sure all over the world people know it. And for India, I can say he's an honorary citizenship we should give, and we want to give him honorary citizenship. So in India, there are 100,000 physicians. They know Peter you very well. So everyone, and we love you. And I love you to see in our Modi jacket, which we used to call Nehru jacket. And we love to show, oh, come on. I mean, he had gone to change the jacket also. So very happy that he is in this, our Modi jacket. That's what that. So you can see how Indian he is and how much love India. With this, I request AV team to show me the slide so I can formally introduce
I
Professor.
forgot to send the slide, so it's my failure that I.
No,
We
no
managed.
issue. But we
We
know that
managed your
you
slides.
are a president of International Diabetic Federation, and we know. I know Peter because his interest in diabetes prevention, and same is with Amit Gupta. He's a leading person in global diabetes prevention and creating care initiative. I know he has done one meeting where I met him first time long back. It's the World Congress of Prevention of Diabetes. Then we met him in Diabetes Asia Study Group as an executive member, and later on in International Diabetic Federation. He has authored more than 370 scientific publications, recognized expert in diabetes policy and research. Actively, he collaborates with World Health Organization, European Diabetes Forums, and various other initiatives for innovation and digitization. And now he wished that everyone should have, in his pocket, the everything about the diabetes. That's what he wished for. As a president of IDF, he started new initiative about the Global Diabetes Index. This is something which we all are looking for. Foundation of Blue Circle Clinics. That's what we are thinking that in India only this year we had given a number by Dr. Peter, at least 1,000 clinic. We should have Blue Circle Clinic. Fasting and diabetes, not just Ramadan, because different type of fasting all over the world. Artificial intelligence in diabetes, type 5 diabetes, so many more initiative. And my dream project of creating a in IDF a virtual museum, for which I am working with Peter, and I'm sure we will get you the first curtain raiser or video or teaser of what we are going to do with this in 75 years. We also have with us Dr. Anuj Meshri, who is currently chair-elect of RSSDI as one of the largest organization of India with diabetologists with more than 15,000 doctors, which is one of the largest organization of diabetologists in the world. We have with us President-elect of RSSDI, which is also a very active member of RSSDI. Amit is very well known across the world. I'm sure India, not all 100,000 physicians who know Peter, they also know Amit, but all dentists, all oral health specialists also know Amit, and they may be more than even 100,000. He is medical director. He's a Center of Diabetes Care and Obesity Care from Greater Noida. He is a adjunct professor of Department of Medicine, KMC, Manipal. He is chair of International Diabetic Federation School of Diabetes. And that's very, very important position, because that's for education across the world, which he is doing a lot of activities for IDF School of Diabetes. This we initiated when we were having Shaukat Sadikot, our president from India. And along with him, originally we started in diabetes school in Diabetes India, in which we thought that it should go to International Diabetic Federation, and now is headed by Dr. Amit Gupta. He's very active in American Diabetic Association, where Public Health and Epidemiology Trust Group, and he's also created a global advisory group, and for which he is the secretary for he's executive council member of our national RSSDI. He's joint secretary of Diabetes India. He's executive editor of our Sadiko textbook of international diabetes. He is also executive editor of our RSSDI textbook. And recently we started one journal, which is Journal of Diabetes and Endocrine Clinic, which we now have taken as an IDF Southeast Asia Association Journal officially, and he is editor-in-chief of that. And with multiple publications, with more than 75 national and international publications, and he's in editorial board many journals, but these are some like Endocrine Practice, as Endocrine, and Diabetes. With this, I welcome first Dr. Professor Peter Swartz and then Amit Gupta. Can I have Anuj Meshri's slide also? Anuj is currently president of Asian Pacific Society of Hypertension, and recently with Diabetes Asia, along with Dr. Anuj Meshri, has written a guideline for diabetes and hypertension, which we are going to publish is from All Asia, is a Asian Society, Pacific Society of Hypertension president and president-elect. I already told you that his RSSDI is currently scientific chair for our RSSDI meeting, which we are going to have at Kochi. He's having multiple awards, multiple oration which he has done. He has himself organized diabetes, RSSDI, very active member of our RSSDI, Diabetes India. He will be with us at ESD along with Amit, and we will be also in Diabetes Asia as one of the speaker, very active member from India, and many awards which he has having and multiple fellowship. With this, I invite Professor Peter Swartz first to talk. Anyone else? Sangeeta?
Sorry, sir?
Anyone else I have to introduce?
No, sir. Now Dr.
So,
Peter can
should we
start his.
start
Yeah.
now?
Right.
Yes.
Right.
Thank you. Once again, congratulations, Sangeeta, for your wonderful initiative.
Thank you, sir.
You are one
Thank
of the most active Diabetes India interest groups. So we
And
really
Diabetes India video was very, very nice. Thank
that
you so
was
much.
superb. So, just before some seconds, Amit, you just asked Sangeeta. I asked, please share that video.
I will.
That's very
I
important.
could not understand.
And
I will
my
share.
own CV slide. I asked from her that please send me that my CV slide also, so I can
will.
share with someone like that.
I will certainly.
So really,
sir,
Sangeeta, thank you for that.
Thank you, sir. Welcome, Dr. Peter. Welcome, Dr. Peter.
Thank you very much. This was a very, very cool introduction, and I must give all this honor back because, for example, with Anuj or Amit or Banshi or Sangeeta, it is such a pleasure to work together. Yeah, Banshi sometimes give me a little bit hard feeling because I think I'm working a lot, but staying next to Banshi, I feel very lazy because he's so much more active than I am. But Banshi has a characteristics. He always comes to me and said, Peter, I think we should do this and this. And he brings brilliant ideas how to change the world for people living with diabetes. I remember, Anuj, where we went together in India into villages to start diabetes screening and diabetes prevention program in the villages. This is a fascinating initiative because you translate what we discuss directly into practice. And this is important. Yeah. If we sit together and we talk nice, nothing changes. We have to walk together to make a difference for people with diabetes. And this is what I always remember together with Anuj. Amit Gupta is for me someone, he's very different than Banshi, but Amit comes and said, Peter, we have this opportunity. I already booked it. So he's really stepping ahead and he is making with all his activities a big change for people living with diabetes. And next week, we all will meet in Vienna, and the week afterwards, together with Amit in New York at the high-level meeting for the United Nations. So tackling the politicians in the world to make a change. And Sangeeta is fascinating if we are talking about oral health, because she never let me from the line and said, Peter, we have to do this and we have to do this webinar and we have to talk about this topic. It is important. We met in Amsterdam at a lounge and we decided to do so. So I would like to give this back to all of you for this commitment and passion and enthusiasm in improving the quality of care for people living with diabetes. And the true leadership in this field is not with me, it's with you, because you do it. You are walking in the right direction. You are working with the patient on a daily basis. And this is what at the end counts. And let's take this opportunity now to jump into oral health and policy aspects. And I have to say, I'm talking about this from a diabetologist perspective or a diabetes perspective, because as it was already mentioned, this topic is neglected in the diabetes world. We are not talking about the mouse. We are not.
We are sorry for that. Please start. Thank you.
What I wanted to highlight that the mouse at the end is a neglected kind of, let's say, an organ in the brain of the diabetologist. And we should change this. And to make a long story short, we have a brilliant opportunity because we could have the chance. And I must apologize for this. I was not thinking about this topic yet. But we might use this event as a starting point. We could think about to develop something on a global scale for oral health and together with metabolism, or oral health and diabetes, and bring some people together. I will not say a guideline, yeah, because this is a very standardized process, but to use the opportunity together with IDF, with all the leaders participating in this seminar, to have an impact in this field. And I'm currently in Dubai, and I was in the morning visiting clinics in Dubai, then in the afternoon in Qatar. Now we are together in India. And I visited a clinic in the last 2 days, and it was a brilliant clinic here in the environment. And so then I walked the floor, and there was written oral health clinic. They said, yeah, this is cool that you have an oral health clinic. And as I am sometimes a bit forward, and I went there and wanted to open the door, and then they said, no, we apologize. Since 2 years, there's no dentist. So since 2 years, we have the sign on the door, but there is no one working in it. And the first step was good, to have the room for the dental clinic and have the room for oral health, but that there was no manpower doesn't translate then into action. Maybe we can change this in the future. Everything was said about me. The unique thing is being president of IDF, president of 556 member organizations with diabetes in the world, an organization which is 75 years old. But very clearly, if we really want to address oral health for people living with diabetes and to improve poor oral health, then we should work together. And we have the opportunity, I will not say during my presidencyship, but there is a critical mass of colleagues who could develop something what is changing oral health for people living with diabetes. Let's go how to translate this into policy. If we look into the epidemiology, it varies from country to country, but oral health is a neglected kind of aspect and organ in diabetes care. And many of the patients actually say themselves that they are unhappy with their oral health condition. And this is significantly related to the quality of diabetes care. To make it again very short, if you have someone, for example, with parodontitis and having diabetes, treating parodontitis improves A1C, treating diabetes improves parodontitis. So both go hand in hand. And I would actually say both go stronger hand in hand than obesity and diabetes. Yeah, maybe it's the same quality like liver fat and type 2 diabetes. We could see also with oral health and type 2 diabetes, but the mechanisms are very, very different. And both of them has an impact on the quality of life for people living with diabetes. And not only the oral health, because, but also the aspect, it's related to their nutritional habits. It's related to their social habits and so on. So it's worth to address this. And as I already mentioned, hyperglycemia worsens oral health. People who have a bad A1C have a higher risk of having parodontitis, have poor oral health control, and have poor oral health conditions. But also the opposite works. If you have untreated infections, then it also has a negative impact on the quality of care for diabetes. And you see here the underlying criteria is subclinical inflammation or inflammatory cytokines, because at the end, visceral fat, hepatic fat, inflammation is one. The dermatologist, if they talk about psoriasis, they say it's an inflammatory marsh. And we could actually use the same wording here, that the inflammation worsens the expression of glycemic control and worsens also the quality of oral health. And then, of course, the dedicated inflammatory effects in the, for example, with the parodontitis, the cytokines have a direct, in the interplay with the visceral fat, and some of them also with hepatokines from the liver, an effect to destroy beta cell function. I mentioned this already. The increased risk of infections in the mouth reduces the quality of diabetes care for people living with diabetes. I'm constantly getting a bling here. I don't know what does it mean. I hope the connection does not break again. But every 4 or 5 seconds I get a bling. And coming back to the oral health again, if the people have insulin resistance, I would actually say the hyperglycemia is a sign, but the underlying pathomechanism connecting to the oral health, it is in 80% of the cases, but this is it's my gut feeling. It's the insulin resistance. It's not purely the hyperglycemia only. It's the insulin resistance who triggers also inflammatory processes in the gum and on the teeth. Then, of course, dry mouth is directly related to extended healing as well as insulin resistance again. There are very interesting studies, not primarily in the mouth, but on diabetes patients after surgery, after interventions, that as higher the insulin resistance is, as longer is the wound healing process. And with high degrees of insulin resistance, it's sometimes 5 times longer. So we are not talking only about hours, we are talking about extending it by 5 times. And an unclosed wound is always an entry for bacteria. And as I mentioned already, poor oral health is directly related also to nutrition and also the abuse of aspects. You discussed this in the previous talk, how to make a difference. And as a short thinking diabetologist, yeah, I would say if I see an inflammation, I have to control the infection and I have to control glycemia. So I have to manage the diabetes very well. We had already in the previous with this previous speaker the discussion about the quality of the biomarker. Again, as a very short-minded diabetologist, I would say if I see it, then I have to treat it, and I should not focus only on diabetes or oral health. I should do both in the same time, because only the combination facilitates synergistic effects to each other and improves the outcome for the patient. What I mentioned at the beginning is we can talk about this in 20 webinars, but the important point is how we can build an environment that not only the motivated colleagues who are here in the webinar, but that everyone else, the 1 million, and I actually, Banshee, think there are 1.2 million colleagues in the world treating people living with diabetes, and this number is constantly increasing. So how can we motivate these colleagues who do not know about oral health, who do not, maybe they're even not interested in the topics, but how can we build an environment that even those don't forget the dentist or oral health for people with diabetes? The problem is we are not cooperating with the dentist. We are not sending the patient as diabetologists to the dentist. Yeah, we might recognize poor oral health, but we are not acting on this because it's difficult. Yeah? In many, I would say, Western healthcare system, it's not reimbursed. If it's not reimbursed, it's not done. And it's not used. Of course, in our university, we have a dental clinic, but if I would refer someone there, then they might also say, yeah, what should we do there? Yeah, so it's on both sides. It's not that only one side is neglecting it. It's on both sides. It's not an established pathway, and this is what we have to change. And as I mentioned already, the awareness how to utilize an improvement in oral health is on a very low level in our healthcare system. So we have to tackle public health. I mentioned that we are with Amit in 10 days in New York at the high-level meeting of the United Nations. And the whole week we discuss non-communicable diseases. How can we improve the environment? And this would be the right spot to leverage also this topic that we generate an awareness on the policymaker level, on the political level, And we will meet ministers of health there in our meetings. And we should go ahead in in a synergistic manner, that not the dentists are fighting for oral health and the diabetologists are fighting for improved glycemic control, that we have a combined approach and maybe a guideline or a combined policy paper or a combined policy statement could foster this. I think in the future with telemedicine, this will improve the situation. And we have to educate also our patients. Yeah, I don't know personally an education program for my diabetes patient for oral health. So it's also in luck in the environment I'm working in, and we should treat the brains of our colleagues to address both in the same manner. Of course, there are vulnerable population as earlier as we start, especially in children, adolescents, and youth. It is important. Pediatric engagement with regular controls. Luckily, we have this in Germany, that the patient or the pediatric patient or the children, they have to get to regular 14 visits to a physician, and 2 of them are with a dentist. But it's 2 in 18 years, and but it's better than nothing. But there are many, many countries in the world who have substantial structural literacy, financial, educational barriers in accepting this. And we should translate this into improved policy. What could be part of a policy like this? Oral health should be included in the NCD management processes. Annual dental checkups should be a way to go ahead. Often, if the parents know that this is important, they might do it. Yeah? So it's an education also targeting the parents of our patient. And often, if the patient with diabetes know the implication, they might go. But they don't know, and we have to close this gap. This is related to patient, but also professional education. We have to develop the pathways. Here is a policy paper or a guideline which can help, and develop digital education and intervention programs for the patient. So it's tightly interconnected, the mouth and the diabetes, or the mouth and the pancreas, or the mouth and the fat tissue on the body, and we need an interdisciplinary collaboration to tackle this. And I would like to make a promise that the doors at the International Diabetes Federation are very widely open to do this. But it's not IDF who sits down and do something, but if we find a critical mass of people who are committed to this topic, yeah, we can provide the roof and the host body for developing a global strategy, position paper, guideline for this topic, because IDF is totally dedicated to everything what we can do to improve quality of diabetes care. And quality of diabetes care is very much related to quality of nutrition. And these are already 2 levels that oral health could be intersected into it, that it's becoming part of the recommendations of the International Diabetes Federation or of a conjoined recommendation. We are fighting for multi-component care, but we often forget the dentist in this care team. So multi-component care together with self-management education. In our self-management education program, dental care and oral health is very rarely included. Though this is a gap and a barrier we have to change. And the WHO is very clear in its targets for diabetes care. 80, 80, 80, 60, 100. Also here, oral health is not playing a role yet. The high-level meeting again and the WHO General Assembly in Geneva in May next year could be the places to leverage this. An IDF policy perspective could be an IDF recognition of the importance of oral health. This would be the lowest level, I would say, but already leveraged level is the collaboration with the World Dental Federation. We have no collaboration yet, yeah, but a letter of intent could be the next step. working together at our annual meetings and maybe developing a policy paper together could be the next step. Then we could do, I will not say a study, but we could assess the realistic scenario, for example, together with the Global Diabetes Index, Banshee has mentioned already, and then use the IDF School of Diabetes for an oral health education program. And I don't see Amit Gupta in the moment, but Dr. Amit Gupta is the Dean of the IDF School of Diabetes. So he could be the right interface for doing diabetes or doing oral health education for diabetes patients in the IDF School of Diabetes. The next higher level, and now we are talking already about a very high level, evidence-based policy recommendation, could come out from IDF or from IDF together with the World Dental Federation, integrating oral health in diabetes protocols. This is a big step to go ahead. We need good evidence. I'm optimistic that this evidence exists. But this could be in the next 1.5 years an achievable target if we find a critical mass of actors in this field. Insurance coverage for dental care. IDF is just starting an accelerator for universal health coverage for people living with diabetes. So this accelerator is like a think tank to develop coverage or insurance coverage models for people with NCD and diabetes. So dental care could go into this. Then furthermore, public awareness and education and training of us, of healthcare professionals, not to forget this. The next level then, so we are talking about the 6th level, is then going into a collaboration. So this means not only talking about it and writing papers, but translating it into action. How to cooperate with the dental colleagues in your environment. Yeah? Often we don't know whether there is one. How to develop interprofessional education and training programs, then to do pilots on maybe national level and integrate dental care and oral health into our disease management program. And then level 7 is going to WHO and the United Nations on a global resolution on oral health, call to action for piloting this, guiding principles, how to integrate oral health into diabetes care, and start in these regions where the burden is the highest. This should be monitored. The Global Diabetes Index could integrate this. This again is something we have in our hand. The people here in the webinar can enable this. Using digital media to help the people, especially in low and very low income environment, because I expect the burden is the highest there as well. Using digital media for education and work with diabetes nurses and to educate them as well with a professional education stream to translate the recommendation in daily oral care for people living with diabetes. There are success stories in the world. For example, Germany, what I already mentioned, there are frameworks who are very active to push this forward. There are good examples of a cooperation between WHO and IDF in various other fields. And there are also good experience in building an international momentum to change something. Think about the World Diabetes Day. Think about activities also for HIV, if we go into a different field, where a combined activities had the potential within years to make a big difference for people with a chronic disease. So I will not say I will offer IDF, but I would like to offer the platform of IDF, the community of IDF, to be the host, to make a difference for oral health for people with diabetes, to make a difference for oral health for people with NCDs, and to make a difference for oral health for all those who have a poor oral health condition worldwide. One example of our view could be the Blue Circle Clinic concept. We are just starting. So the dream is in 10 years to have 10,000 Blue Circle clinics in the world. Banshee already promises thousands from India. But let's develop this step by step. And the idea behind is that the Blue Circle Clinic is an existing clinic which gets a license or a plug if they follow a certain standard. And now let's think, if we work now hard and to include oral health into the future diabetes standard of the International Diabetes Federation for the Blue Circle clinics, this could be a very big step ahead. And our goal is to standardize and leverage the quality of diabetes care. There will be different levels. And at the end, it's a kind of core concept to enable better accessibility and availability of evidence-based diabetes care for people with diabetes worldwide. And oral health could be part of this standardized concept next to many other aspects which we just have discussed as well. So it's a call to action. Let's think about that we are not only talking, that we start walking together to harmonize guidelines, to bring oral health into the diabetes guideline and diabetes into the dental guideline, to talk to the policymakers, to develop modern policies and integrate modern technology into oral health. I'm very optimistic that in the future, if a patient has a CGM sensor, I know that they are still expensive. This will be over in 3 years. I think that we have very cheap sensors available. And the analyzing the variation of glucose over the day for a week or 2 weeks, and with the use of AI, will help us to identify people who have a poor oral health translated into less glycemic control. So there's a big opportunity for the future, but we have to set the rules now. The call to action could also be to develop registries, including oral health, to develop not only pharma, especially also insurance company partnership, to talk to the communities how to roll out program like this. At the end, a global collaboration between the diabetes organization and the dental organization. We should never forget, at the end, we do this for those people living with diabetes, because it's our interest, our objective, our perspective to address the need of these people living with diabetes, and a better oral health is a need of many, many of them. And let's work together to address this. At the end, prevention from the diabetes perspective is all about physical activity by walking steps is the way to prevent diabetes from developing. Smart health will disruptively change our ways to do diabetes care and also dental care, because we are in the pocket of our patients. This is a brilliant opportunity to be in the pocket of the patient, because better understanding our patient needs and being in the pocket is a direct interface to the, let's say, the soul of the patient. And we can use this to improve also oral health. As president of IDF, I have installed a number of new working groups. One is related to fasting and diabetes. And this will tackle the inflammatory origin in the liver and the visceral fat for people living with diabetes, led by Mohamed Hassanain and Daniela Koppelt, addressing numerous different fasting styles for diabetes care. AI and diabetes, I just mentioned the future power of AI. Amit Day is leading this, and we will have in a few days in Vienna a core meeting regarding this. Prevention of obesity and diabetes is led by Ines Charltooth. They just have released a public health plan for diabetes prevention. Oral health is not included there yet. So this would be one of the first steps to change. Type 5 diabetes, this was also an Indian initiative led by Neha Thomas together with Meredith Hawkins from the US. And this is also a neglected kind of disease, also related to poor health. And they will come up in the next 1.5 years with a guideline about this. Similar to type 4 diabetes, GDM, led by Dr. Mohan. You see a lot of powerful Indian colleagues in this field. And the dean of the IDF School of Diabetes, Amit Gupta, who will develop the revolution in diabetes education and hopefully including oral health in the future for the diabetes world. As president of IDF, I have 3 goals: to be in the brain of the politician, to be in the pocket of the patient, and in the heart of every healthcare professional. The brain of the politician, we will reach by doing a global diabetes index, which was mentioned already by Banshi, once a year, asking 100,000 patients and physicians all over the world to translate the answers into an index and make the diabetes care in Kerala comparable to Wisconsin and Helsinki. And we will feed this back for free to anyone to use it to build a momentum for politicians to change something. Being in the pocket of the patient, of course, it's digital diabetes education, freely accessible, to help the patient to understand better his diabetes, and maybe including oral health in this as well. And finally, becoming fellow of the International Diabetes Federation. Any one of you is invited to become fellow of IDF, to build a global community of actors to improve the quality of diabetes care and to make a difference for diabetes care and oral care for our patients. Not an old organization, but an experienced organization. And under my leadership, together with the following presidents like Niti Paul, we will work hard to, I will not say revolution again, but really to leverage the activities to improve the quality of diabetes care, breaking down the barriers, sometimes in our mind, our clinical inertia, barriers on policy level, barriers on accessibility and availability of diabetes care level. And this could be the same also for oral health. Social media, I would love if you, or would be very happy if you would follow some of the channels, because this is the way we are informing about the activities and also give an opportunity to participate. Also on WhatsApp, if you are interested, you can scan this and follow. Don't forget these faces of people living with diabetes, because they deserve a better life, a better glycemic condition, and a better oral health. Let's work together with our intuition, our goals, our professional expertise to finally help our patient to walk away from diabetes, but in the best case, with an excellent oral health. Shukriya, thank you very much for your attention. I used the wrong word for thank you because we are in India. It's not namaste. Thank you very much for your
Dhanyavad.
attention. Dhanyavad. Yeah, I forgot it. I apologize for this. Dhanyavad.
Dhanyavad. Dr. Bansi sir, are you there?
Yes, very much here.
Kindly conclude Dr. Peter's session, please.
It was wonderful session. You know, he talked about Blue Circle Clinic and new initiative, type 5 diabetes, everything he talked, and he started with the oral health issues from a diabetologist perspective. So every aspect is he had covered. We can have some questions, some comments from Dr. Amit, from Anuj, and we will be asking some of the questions to Peter. I mean, are you looking for a blue circle clinic, which is like we were thinking of 3 circle or 2 circle or 1 circle? So someone who have a 3 circle or in 2 circle, where you would like to put a dentist or a dentist should be a part of center? Will you be considering it with triple center, which is a tertiary care, or with 2 circle? We are sure that with 1 circle, we are not looking for. That's a primary care, a diabetologist, which is a physician or a primary care physician. Just he is the one who is taking care of it. But I mean, in triple center, we can put it.
But Banshi, I would say, why not in all levels? Of course, in if we think about 3 levels, so 1 blue circle, 2 blue circles, 3 blue circles. 1 circle is the very little diabetologist or GP office, but doing a lot of diabetes care. The next level is a larger diabetes office who are also educator available. And the 3rd level is a chain of diabetes clinics who are also research is done. So having a dentist probably is in the 3rd level. But I think in the guidelines and in the standards, we would be able to include the hint also to have a kind of documentation. Maybe the lowest level is a documentation of oral health is necessary also in the lowest level. If you look at it, you also make a recommendation, and this could be the starting point to include oral health on all levels of the Blue Circle Clinics concept.
Right. I mean, at least what we can say that at least they should be connected with some oral health specialist where they can refer their patient, if not in their
Yeah.
own center, that can be possible.
But to be critical from our side, in the moment in the development, it's not in. So
Right.
we made the same mistake ourselves. Yeah, we were looking onto glycemic condition, maybe a little bit obesity, but we forgot oral health in the current drafts of the Blue Circle Clinic concept. So it would be the right moment to make the difference now.
So, Peter, in India, there is a now Clinical Establishment Act is coming, and they had come out with
Yeah.
some guideline that each and every clinic should have. And I'm preparing all those short notes for you. I will be coming and I will be giving you day after tomorrow personally, and also give you the soft copy. And we are also talking our NABH, which is a National Accreditation Board for Hospital, and they are also coming out with the clinic,
Yeah.
particularly for diabetologist clinic. So then there is a NABH is coming for a diabetologist clinic. Some draft I have. So I'm preparing that how we can use some of these points in our Blue Circle clinic.
Yeah.
So these we
was
can
last
include
week-
or exclude.
Yeah, I was last week in Saudi Arabia, and I must say I had no idea. But then the deputy minister of health in Saudi came and said he gave me a 5 pages document, standards of diabetes care in Saudi Arabian diabetes clinics, and it was brilliant.
Wow.
So there's a lot existing, and our disadvantages we often don't know. Yeah, a country is developing something, and even the neighbor doesn't know. And this is where we should make a difference and use the best practice examples and leverage to a global level with the Blue Circle clinics. So I don't
That's
want
great.
to reinvent a wheel, but I want to use the best practice examples and give them a global perspective.
That's great. Anuj, what's your perspective for RSSDI point of view that all those RSSDI members, those physicians who are practicing diabetes, they should have a minimum standard of care at primary, secondary level, and tertiary care, where we will include that they should have either in their clinic or a collaboration with an oral health specialist. How important and what more we can do for India.
Thank you. Thank you, Banti, for this question and this opportunity. Really, the important is to screen each and every diabetes patient for the oral health, which is not really being followed across the country in most of the diabetes clinic. And truly speaking, it has not been yet entered in our protocol. Neither RSSDI guidelines has ever released any instruction or any suggestion to screen each and every patient of diabetes for the oral health, which is very much needed. And I shall be looking forward to work on that. First of all, I look forward to collect the data, and this could be requiring an integrated approach, oral health practitioner, dentist, as well as diabetologist and endocrinologist, and would be looking forward to have such program, such research activity on the RSSI platform, as we have done earlier also, like hypertension and like many other things, would look forward for oral health screening kind of the activity. And on the basis of what would like to introduce into the guidelines of the RSSDI, so that each and every person, RSSDI as a biggest organization of the diabetology, and if it brings the oral health in its agenda, definitely it would be coming to the each and every diabetes clinic. This could be an approach for me, and I would work on that.
So in past, like we have worked with Vitreoretinal Society in the similar way, we can also work, Sangeeta, with RSSDI at a national level, either with periodontal or with any other particular sub-society where we can.
Sure.
Amit, we can think of also what's your thought
Yes,
to
yes.
create any modules on oral health for IDF school?
So,
Because in some parts of the world, I'm sure the awareness, when you can say India have highest number of diabetologists and highest number of people with diabetes, but still, if awareness is poor, I'm sure in some parts of the world, the awareness must be very poor. So what we think and what we are planning for that.
So, sir, as you know that I have already shared a detailed agenda and almost 340 topics with the Dr. Peter as well as you yourself also. And when we are coming with the global curriculum for the IDF School of Diabetes, the oral health is going to be a very, very important component for that. And the modules will be prepared. And just an idea came and when the Dr. Peter showed this Blue Circle Clinic and very nice pictorial depiction of a blue circle clinic. So I just had this idea in mind, Dr. Peter. Maybe we can now start making spikes of the circle. What are the 12, 14, or 15 essential components of the circle to make it a full, complete diabetes clinic? This may be oral health.
Ah,
Yes. For example, in India, we have this Ashok Chakra, which is represented in Indian flag. We have RSSDI wheel. So every wheel has some spikes or you can say spokes, right? So we can have with every spike, we can say we can define that what should be the component
yeah,
of the care.
yeah.
So after looking at your this parliament type of structure for the diabetes clinic, it just crossed my mind that why don't we have this approach where now we start defining what should be a blue circle clinic, what should be an ideal blue circle clinic, and obviously one of the component of this blue circle clinic can be oral health as well.
This is a cool idea. Because sometimes it's such a picture which makes a difference. And if it's too complicated, the people will not understand it. But if you can easily visualize it, there's a high probability that people understand and follow. What I wanted to do is to give a very clear statement that the doors are open to also to accommodate an initiative of the people who are saying we are passionate to do something for oral health, for diabetes care worldwide. Let's do it. Let's not only talk about it. Let's come together, discuss what we want to, what is realistic to get achieved in the next 12 months, and then let's do it. And um, we will not fail. I'm very sure we will. It will become a success story.
So very true. Even our oral health may be poor, but one thing which I should admit and I should congratulate to all our oral health specialists and dentists. When I was child, I used to see people of age of 60 or 65 without teeth. And now I am not seeing even a person at the age of 80 without teeth in India. I mean, now I'm hardly find anyone who is not having teeth or having decayed or not on a. So I'm sure the oral health and overall dentistry is improved because thanks to number of dentists and awareness is increasing even in a rural area. My village is a very small town where we started our diabetes clinic as a village clinic. But now I am not finding. We have in our town also. I mean, that village is now almost more than 5 dentists, and they are taking care of people of this town also. So I mean, it's definitely improved, but still it is very poor, Peter, because we have one very bad habit of many people are addicted with masala, tobacco. They keep on chewing, and that may be the reason that we have highest number of oral cancer in the world. So one of the leading cancer in India is a oral cancer, and a lot of people they go. There is a dedicated branch in cancer surgery which is taking care of only head and neck. They also need dentists, they need plastic surgeon, they need head and neck cancer surgeon. So it's very much increasing. And in my clinic, in last so many years, we have detected just because we have a dentist. So in a routine clinical examination by a dentist, we are picking up every alternate month or every once in 3 months or 4 months, even 1% of leukoplegia or cancer or pre-cancerous conditions. That's very, very common. So we need more. I mean, Sangeeta, do you want any other question?
So yeah, we have to just officially start the panel discussion, maybe with your permission, sir.
Yes, please.
Okay. May I just request Dr. Sumedha to kindly just introduce the remaining panelists? Few have already been introduced. Maybe Dr. Balaji Manohar and Dr. Anurag Satpathy, please. Dr. Sumedha?
Yes,
yeah.
Please, can we have the intro slide of Dr. Balaji? Dr. Balaji Manohar, an alumnus of A.B. Shetty Memorial Institute of Dental Sciences, Mangalore, is a fellow faculty of dental surgery at the Royal College, Glasgow and Edinburgh. He also has a master's degree in hospital administration. He has a teaching experience of over 25 years and has several accolades to his name like the Dr. A.V. Vasantrao Award, Dr. I.R. Gola Award, and most Proactive Senior Academician Award, to name a few. You will see him in the forefront of several researches and publications and guiding postgraduate students as well as PhD scholars from 2006 onwards. He has an extensive organizational experience and has honorary secretary of the Indian Society of Periodontology. He has been a part of the Indian Dental Association as the honorary secretary of Udaipur branch and joint secretary of Rajasthan State branch. He also won the runner-up award as the editor of the Rajasthan State Dental Journal for the year 2015 and 2016. We welcome you, sir. I'd just request Dr. Gunjan to please introduce Dr. Anurag. Dr.
Thank
Gunjan.
you so much. Thank you so much, Dr. Sumedha ma'am. Can we have the slide for Dr. Anurag, please?
Is there? Yeah.
We welcome Dr. Anurag. He is our next panelist. Dr. Anurag Satpathy graduated from Bharati Vidyapeeth Dental College and Hospital, Pune in the year 2001. Completed his post-graduation in periodontics at SDM College of Dental Sciences, Dharwad in the year 2007 and earned his PhD in Dental Sciences from Shiksha O Anushasan University, Bhubaneswar in the year 2021. A prolific researcher with over 100 index publications and 950 citations, he has been consecutively featured in the Yeah, there was a technical glitch. I'm so sorry. A prolific researcher with over 100 index featured in the AE Scientific Index. He has filed 3 patents, 2 of which are granted and consistently published in Q1 journals. He has also contributed as a lead author in book chapters with Springer Nature and elsewhere. Dr. Satpathy serves as editor of Journal of Orissa State Dental Association, is on the editorial boards of 2 Springer Nature Journal, a guest editor for Scientific Reports and Frontiers, and an active reviewer for multiple high-impact journals. He has held leadership roles including executive council member of the Indian Society of Periodontology and scientific chairman of its national conference at Bhubaneswar. He also serves as member secretary of the Institutional Ethical Board, Institute of Dental Sciences, Shiksha Anushasan University, Bhubaneswar. We welcome you, Dr. Anurag.
Thank you, Dr. Gunjan.
Thank you, ma'am.
We will now initiate the panel discussion. Maybe the first question can be put up to Dr. Peter, please. Sir, so basically we would like to understand your opinion, sir, in the countries with limited sources. What would be the most effective cost way to integrate oral health screening into the National Diabetes Program, sir?
I would say the first step is having a national diabetes program. It would be already a big step ahead. Many countries in the world do not have a national diabetes program, but if it exists, this could be the hub also to include oral health. Unfortunately, most of the countries in the world do not have a national diabetes program. And this is a momentum where IDF could step in, that we say, we develop together a clear recommendation how to include oral health in hyperglycemia or diabetes care, because many of the colleagues do not know about this. They don't value the aspect. They neglect oral health as part of diabetes care. And this is our task, what we should change.
Right, sir. Right, sir. Dr. Bansi, sir? Okay,
yes, I am here only.
Okay, Dr. Bansi, sir, this we would like to put this question to you, sir. As private practitioner, sir, what are the practical steps, in your opinion, to improve the referral pathways between the dentist and diabetologist, sir?
So, I mean, it's required a lot of awareness. First, awareness to the primary care physician, doctors, and at the same time, patients also. So what happens, the patient is coming to me for a glucose control. He does not have any idea that I'm going to ask the person that you should go to my dentist also to show. And he is not having neither budget for it, nor he is concerned that why doctor is asking because he is having clinic. So what I have done is that each and every person who is coming to my clinic, this is included in parts and comprehensive. We don't charge extra, like we don't charge for extra nutrition consultation. We don't charge if my assistant is seeing patient, educator is doing everything. It's like a comprehensive package. So your patient did not do any charge. Now, what happens if I don't have a dentist in my clinic and if I refer the patient to some dentist, he is going to charge for a basic consultation also. That's a big challenge. So how and what best we can do, because in India is they have to pay from their market. Internationally, there are two type of market. One is patient has to pay from their pocket, and the other is everything is insured. In the insurance market also, is it included in insurance? Because most of the places in the world, the dental insurance is completely separately. I mean, a person going to a diabetologist will not get insured, will be not be covered for the dental even examination also. So these are the challenges. And I think these challenges, when we will be writing from idea perspective, these challenges are more. If I'm just thinking of India perspective, the things may be different. Now I'm thinking from Southeast Asia perspective. So like Nepal, when I was talking, in Sri Lanka, everything is government. In government setup, they don't have. Even in the burden, which is one of the biggest world center for diabetes, you can say, which is WHO supported, government of Bangladesh supporting, every day thousands of people are there to see, but they don't have such a big department for oral health. So we need to work with the doctors first, and then we have to do a lot of advocacy in the place where it is insured or not insured market, something like that. And we have to create, like as Anuj has said rightly, now in our guideline, we will be putting, we have already 15,000 doctors. We will try to work with you people and try to increase the awareness first to the doctor. If doctors start telling that, yes, you should go. Like, you know how fundoscopy increased. Before 15 years, nobody was worried about their eye examination. We decided no, each and every person should go. We work with Veteranal Society also, Eye Surgical, Ophthalmic Society. Then now, thanks to this, because of telemedicine and with AI, now that fundus camera is so cost effective that I can keep in my clinic and need not to have a ophthalmologist or retina specialist with me. So just AI catch the picture, pick off retina. We can decide that whether it's the abnormal or normal. It goes to my retina specialist also. So out of 40 patients we screen or 30 patients we screen for today, if 3 have the problem, then only 3 patients has to go for the doctor. Other 27 have not to go, and for them they have not to pay anything from their pocket. So I mean, this is the most cost-effective method. The early detection, we can detect and we can send the patient for that. So some solution we have to bring. It's a Indianized solution we have to get, but each country have to find their own solution. And similarly, IDF has to create some guideline for new circle clinic, because insurance is not paying for dental insurance, that I know in some of the countries. That's a challenge.
Sir. Right, sir. Dr. Anuj, sir. Dr. Anuj, sir.
Sorry, Peter, we all work till
Yes,
late.
I am here.
We have patients also, so everybody is seeing patient.
Yeah, I know. Sir,
No,
this is for you, sir. Should oral health screening for diabetes be mandated at the primary care level, especially in the dental clinics? What would be your point on that?
I think this question should be a little reverse, and what I would say that it should be mandatory to every diabetes clinic.
Both ways, actually.
Already, dental clinic or dentist clinic is already looking for the oral health. Any patient goes to any dentist, obviously he is going to see the oral health. But a diabetologist, how much concerned about the oral health? This is more important. And I think myself and Amit both has worked on dental college sometime. So we understand the importance and we understand the lack behind this. People are really not very much looking forward for these diabetes related complications, and they are not really aware of something for which we are not aware. Obviously, we shall not be looking forward. So that is the issue for which I would like that each and every diabetologist and endocrinologist, any physician who is practicing diabetes must know when should a patient of diabetes be sent to dentist clinic. He should be screened, and every patient who is coming to our clinic, may it be of the 10 years diabetic, may it be of the naive diabetes, he should be mandatorily screened for the oral health. What comes out, what doesn't come out, that is another thing, but screening must be there. So in fact, I'm keeping a topic also in coming RSSDI on this talk, that every person should be screened for that oral health.
Good.
Fabulous. Fabulous.
Sangeeta, I
Thank
have
you,
one
sir.
question to you. You are
Yes, sir.
working in a multi-specialty hospital, and you
Right,
have in your center where endocrine diabetes clinic is also there, and you have big department of oral and dentistry, everything. How
Right.
often, I mean, you find that people are referred in the right way, and what is the best possible, a comprehensive diabetes come oral health clinic you could start in your hospital? I mean, this is just a if you have done the best thing, then that practice can be done in other multi-specialty hospital, at least not in a private setup. Because now in India, there are 10,000 big hospitals which have
Right.
more than 100-bedded hospital, and then they
Right.
have dentists and diabetologists both in the hospitals.
So the bridge, as I have to say, it is a challenge to put the word across to the physician diabetology community, that I would have to put it like this. So it's not easy that everyone was going to be like-minded. So if I have to address it, my center, I've got almost like 7 diabetologists, but each one's wavelength is different. So one would be pally in understanding it, and the remaining 6 will not be. So yeah, if it is to be agenda that has to be mobilized, then it's a challenge to take it forward. And I'm
Balaji,
sure it will work. But yeah, it has to be taken as a challenge. It's not easy.
Balaji.
Dr. Balaji.
Yes, sir. Your query is very valid, sir. And what Sangeeta also has told is very true. Most of us, me, Anurag, most of us are working in institutions where we have medical colleges as well. But very rarely do we see that the patients are referred from the medical side or the diabetology side for a dental checkup. So it really requires a lot of initiative and effort from the dentist point of view to convince and ask them to send patients for actually the benefit of the patient himself. Anurag, your take?
Specialty hospital,
Sir.
I mean, Sangeeta, you can reduce the consulting charge for that. And for Balaji and Anurag, who must be seeing in a public hospital where everything is free, they need their colleagues who are working in the medical side or diabetes side, how to convince them to send the patient for regular checkups. I mean, these are some of the things. If we at least start doing in some of the tertiary care setup, then I'm sure it will percolate in your primary care too. Yes, Anurag, want to
Sir,
add something?
thank you, sir. If I may, like we have been discussing today, Dr. Mariano's science was putting forward the evidence that yes, periodontal care does decrease the glycemic level, but yet there is a disbelief. The communication with the medical fraternity is not complete. And when we are in an institution where there is medical college also, what I have initiated is that we have reached out to the hospital, to the top bosses, and they have allowed us to discuss with the medical colleagues to put in place a practice that before any surgery, especially cardiac surgery or any surgery, there has to be a mandatory dental clearance. Now, what it makes important is that when it is not in paper, nobody does it. But when it is in paper as a protocol, people like to tick the boxes. Now, sometimes it may cost money. Yes, that is true. But when it becomes over a period of time, people tend to see the results. Now, especially for the diabetologist, as Anuj sir rightly said, that the dentists have been shouting from on top of their voices that please look into these patients. But on the other part, I'm really thankful for practitioners like you who have the dentist in your own clinic. But this practice is not everywhere. Perhaps this concept and clarity, if it percolates with the endocrinologist, that just like you are sending a patient to a cardiologist or a podiatrist, the quality of life of a patient is important. At the end of the day, we want the patient to get well. And if we are able to diagnose that there is an ailment, the patient might be coming with a bleeding gum or a shaky tooth or a foul breath. These are simple things that we can ask that please visit a dentist. Yes, he might say that this is not important because it's not life threatening. It is true. But I think if it is a protocol, if we are trying to push it slowly and slowly. And if, like Dr. Peters has promised that he will take this to the global level, and at least he'll try his level best, then things will change. But yes, you are right. It is true. And maybe a small group of us, we are trying with you to at least push this forward amongst others also. I have made this initiative in my own hospital. I've spoken to the chairman of the university, and he has been kind enough to agree to this fact that in the medical college that he has put this into the practice.
Right. That's a brilliant thought you have shared, Anurag. Dr. Peter, can we
Yes.
have one question to you as well? Now, in your country, whatever realistic level, as a real ground level, whatever is practicing, how do you think in your developed country like yours, can there be some model of care to integrate the oral and metabolic health in India?
Yeah. So until the patient's 18, we have a good model in Germany that there are dentists, pediatric dentistry, and it is accessible to the children. Sometimes the dentists actually go into the school or also the kindergarten. So the dental care until you are 18 is good, and afterwards it's lost. And there is no regulation with to integrate dental care into diabetes care. And I would say it's probably more difficult in a country like Germany or Europe to change this than coming from the global perspective. And our German diabetes organization is very conservative, very strong. I experience many diabetes organizations in the world being much more open and dynamic. But as I mentioned, that IDF develops a guideline on fasting in diabetes. They came and say, okay, if this comes, we translate it in Germany. I was a little bit surprised, but this could be the way, coming from global and then motivating the national organizations to adopt what is coming from global. Working with WHO, ADA, EASD, I think could be helpful. And this is what I would recommend. Let's start with IDF, then integrate WHO, ADA, EASD, and by this, rolling out it to all the other countries. So I want to repeat this. During my presidency, the doors are very, very wide open to start this and to develop something. But the initiative should come from your side, because we cannot develop this guideline. Maybe Banshee can, but me not. So the people in this webinar will say we are passionate, 15, 20, 25 persons together. I think we can make a difference for people living with diabetes in the world.
Certainly, sir. We'll try to bang IDF doors in your presidency. Certainly, sir.
Very good. But I have to apologize because in 4 minutes I have the next meeting.
Absolutely. Within 5 minutes, we'll just kind of bid favor to you. Yeah, Dr. Balaji, please. Yes, Dr. Balaji.
Yeah, Professor Peter, thank you very much. You gave a wonderful lecture, and I'm very impressed by the 3 goals you are having of being in the brain of the politician, in the pocket of the patient, and in the heart of the caregiver. Compliments to you, but at the same time, I want to tell Dr. Bansi and Dr. Amit and Anuj that Professor Peter has put a big goal in for them also, because he's expecting about 1,000 Blue Circle clinics. And Amit also has told that definitely the dental integration has to be there in these clinics. So we are really looking forward that this integration does take place, and Professor Peter, under his presidentship, is able to impact the global circles and make this a success, and give us all the patients a very good quality of life in the years to come.
Right.
Thank you very much. Thank you for this statement.
Yeah, Dr. Anuj, are you there? Dr. Anuj, sir?
Yes, I am here.
Sir, one question for you, sir. You, as the incoming president of RSDI, what role can professional societies like RSDI, IDF, FDI play an influence in the national policy on this integration, sir? This question will roll over to you as well, Dr. Peter, sir.
First, I should answer, then
yes,
Dr.
Please.
Peter will
yes,
answer.
Sir.
Right. So, I think everybody would be agreeing that we should work for a national policy, national guideline, in which oral health should be given some priority. And oral health, because any part of the body, if remains neglected for the health, for the diabetes point of view, then all efforts just go in vain. They are not going to materialize as a good control of the diabetes as well as a freedom from complications. What would be the aim for each and every one, and what should always be the aim of each and every diabetologist? And that happens too also. So we should look forward to make a committee, make a group of the expert people who can decide about the guidelines, about the roadmap, what should be followed by all diabetes practitioners in India. And definitely, India is matching with many of the neighboring countries too. If we shall be making such kind of the roadmap, that definitely would be followed by many of other IDF countries, and definitely we should look forward a help from IDF. Dr. Peter Schwartz should also give us his advice, and Mamit is already there connecting with them, and of course Dr. Banshi Sabu, and we all can make a national guidelines and national roadmap with which we all work, and we can never forget the Dentist Society. So we shall definitely have your help, because you would be the most important part of that, who can work on and who can guide us. And you can really tell that what is the right time when a diabetologist should send the patient to dentist.
Right.
Yeah,
Your point, yeah.
Anuj, thank you very much for this. And I would like to add, let's change together the world for people living with diabetes and who have poor oral health. I think if we get the critical mass of the experts talking here together and say, we start the process, and maybe the guideline is not the first step, but it's a roadmap, a policy paper, and then followed by a guideline, which has the global implication, and we get WHO on board, I think we really can change the quality of life for people living with poor oral health. And I think this is a brilliant goal to go to. I repeat it again, the doors are wide open. I would be very happy to be part of this group. Let's do it. But I have to jump now because since
For your
1 minute,
meeting.
the other meeting started.
Sure.
It was a great honor to be here with you. And I hope to see you at the kick-off meeting for the oral health and diabetes guideline again.
Absolutely, sir. And thank you so much for accepting the invite. It's a pleasure and honor to have you, sir. Namaste, sir. Thank you.
Namaste.
Thank you.
Dhanyavad.
Dhanyavad. Namaste. Thank you. Thank you, sir.
Ciao.
Thank you.
Dr. Amit, you will roll one question. Okay. Dr.
I
Anuj,
think-
sir, one more question for you.
Yes,
What would
yes.
be your research initiative, sir, that you would like to prioritize in the next 5 years to strengthen the oral health diabetes connection in India, sir?
Yeah, this question is for me.
Yes, sir, you're for you.
Oh. The most important thing, I think this is the area where the least research has been done. And whatever research is done, which has not been organized, and it has been done by few people in a small segment, 50 patient, 100 patient, 25 patient, that kind of the research has been done. So what is my opinion in that? We should have a organized research, a structured research across the country that should be multi-centric. And after getting the results of every center, we should reach to some conclusion, and first we should know what is the current status, what is the problem load in our country. Then we should look at what kind of the treatment and what kind of the methods are people applying for the diagnosis. Are they really sufficient or not? If they are not really sufficient, what we can add, what additional we can offer to them, and all this should be in a affordable manner, so that each and every patient, whether he belongs to the good sophisticated place, or he belongs to the villages, rural area, or coming to the primary clinic, or coming to the tertiary clinic, or coming to the corporate hospital. Everyone could be able to afford. Affordable care is the most important thing. We should look forward for that. So this is my, if I could given the free hand to design research for the 5 years, I would be working on this pattern.
Correctly put, sir. Dr. Bansi, sir, would you like to add to it anything before you leave?
Perfectly fine. Anuj's research had, the RSSGI had. So what more I can add to the research?
Absolutely, absolutely. Okay, so
whenever I will make any plan, I think Dr. Bansi would always remain the integral part of that.
100%.
And I had not done anything in my life in which Bansi has not participated. So
always there.
So we shall always be together in that way also.
Right, right, sir. Dr. Amit, sir, I think we should just sign off. Maybe just add few points from your end, sir.
So I think, first of all, let me congratulate you. It was so fantastically set up right from the video which you showed about the Diabetes India, then the profiling, and this is the quality of a leader. You did not show only the oral health, but you listed all the interest groups in that listing. It was really nice to see. And Dr. Peter, Dr. Mariano, I just came to know that he is in India. If we would have known before, then probably we could have arranged something in person also. But since we were not aware, so please do think of this next time whenever Dr. Mariano is in India.
Yeah, he's on a touring visit basically, na? So he just came from Mumbai in the evening only.
Yes. So again, it is really nice to have such a eminent personality in the field of periodontology with us and coming on this platform, giving his insights. And Dr. Peter Swartz, he's as usual, always dynamic, fantastic. So whenever you listen to him, I believe he may be he can be one of the director of the WHO next time. So he has such a, and this is our experience, and Dr. Bansi sir will also agree that right now the IDF is most open to ideas, to people, to the inclusiveness. And any idea you throw on Dr. Peter or Dr. Bansi, and they will say, yes, let's do it.
Right.
So there is never a no in IDF right now. So nobody says no to any initiative or anything. And I think today we had this very good discussion. I will just put up a mail and copy all of you and copy Dr. Peter, Dr. Anuj, and let us see that how we can take this forward. And so that this discussion doesn't stops here.
Absolutely.
So we will do something concrete out of it. And I am really lucky to have my mentors, Dr. Bansi Sabu and Dr. Anuj Maheshwari. Everybody is here to bless me and guide me. And this, as Dr. Bansi already mentioned, this is one of the most happening interest group of the Diabetes India. So more power to you.
Thanks to you also, the kind of support that you have always been, freedom to do whatever you people doing it, and that's what it is going forward.
Sangeeta, hundreds of people should join, thousands of people should join.
It's just that we are like, you rightly say, physicians, how to wake them up, you have to tell us, how do we wake them up?
I mean, really it's difficult, but still, it was really very interesting.
Right. In fact, we are planning to create some sort of a documented, piece of paper for this webinar specific. We'll try to see something work out with all the discussions collated now. We'll try to create our documentation from this and maybe just host
only what we have to request that, Amit should put it from his LinkedIn or his profile. Then thousands of people will follow it. Otherwise,
he is a
the only guy who can make the people to follow is, Amit. So you have to give him everything in advance. Right. So I'm sure many people will follow. But we have to make it more popular and more doctors should join. That's what I wish.
Right, sir. So,
Sangeeta, you can definitely forward to Dr. Amit our membership link. I had already sent once to him. So probably he can float it once again in his other interest groups as well.
His signature will work, run.
Yes, it definitely will.
Sure, sir. So with your permission, Bansi sir, should we wind up the meeting, sir?
Yes. Thank you. I will have to go home.
Thank you all for your presence, and till we meet next, thank you so much and good night.
Thank you.
Thank you so much.
Thank you so much, Amit sir.
Ahmedabad, Vipul and Dhruvi joined.
Yeah.
So from there also. Thank you.
Yes, so Sangeeta ma'am invited us. It was a wonderful program. Congratulations, ma'am.
Thank you so much for joining, Dhruvi. Thank you so much. Thank you.
Congratulations, ma'am.
Thank you, Vipul sir. Thank you all. Okay,
Thank you,
then.
Dr. Sangeeta.
Thank you.
Bye,
Good
bye,
night.
bye,
Dr.
bye,
Bye-bye.
Dr.
Thank you so
Balaji,
much.
Dr.
Thank
Gunjan,
you, sir.
Dr.
Thank you, sir.
Sumita. Thank you, Bansi sir. Thank you, Anand sir.
Thank you.
Thank you, everyone. Thank you so
Good
much.
night.
Okay, sir.
Good
night.
Good night,
Good
sir.
night.
Good night, sir. Bye. 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 Jignesh?